Good afternoon, everyone. I'd like to welcome you to our session today. On behalf of Flagler Cares and One Voice for Volusia, welcome to the 2021 Health and Human Services Summit. My name is Lori Clark, and I will be the moderator for this session. You have joined the session titled Volusia Flagler Children's Services Staffings and Baker Act Training. All participants will be muted during the training, and there will be a Q&A time at the end of the session. You may raise your hand using the reactions button at the bottom of your screen, and we will unmute you. You may also submit questions during the chat, and we will pose them to the trainers throughout the session and at the end of the session if time allows. Thank you to the sponsors who made this event possible: Advent Health, CareerSource Flagler Volusia, SMA Healthcare, Magellan Complete Care, Department of Children and Families, and the House Next Door. It is my pleasure to introduce you to your trainers for this session, Christy Gillis and Maggie Svitikin. Go ahead, ladies.
Good afternoon, everybody. Again, my name is Christy Gillis. I am from the Florida Department of Children and Families. I am the Community Development Administrator, and I'll let Maggie introduce herself, and then we'll get started.
Good afternoon. I'm Maggie Svitikin, and I'm the Regional Substance Abuse and Mental Health Director from the Florida Department of Children and Families for the Northeast region.
So first, we'll be starting out with the staffings that are available for children and families in Volusia and Flagler, but this also applies throughout Circuit 7, which is Volusia, Flagler, Putnam, and St. John's, as well as most of the staffings are available to individuals within the Northeast region. So first of all, the Department of Children and Families, many people know of us because of investigations and with the child welfare, but there's a lot more that we do. We also have the abuse hotline, the access center. We do adult protective services, child care, and background screenings. Again, the child welfare, domestic violence, homelessness, interstate compact for children, refugee services, and substance abuse and mental health. The department has a new agency goal, which is a prevention model versus crisis response, which includes care coordination, and care coordination can look different in the various programs within the Department of Children and Families. Again, these staffings that we're going to go over are for Volusia and Flagler County system staffing processes. We'll be talking about various charts as they relate to children that are in the community, as well as children that are in foster care. You'll also have an understanding of who takes the leads within those staffings, and you'll also see that there's many opportunities to assist youth and families that have high needs or that are involved with multi-systems. So first, we're going to talk about the Family Services Planning Team. Some of you may have participated in a training that was held earlier today. Family Services Planning Team, the purpose is to link families to traditional or non-traditional services and stabilize children that are in the community that need a lower level of care. If you have a child that is in the community, meaning not involved in the court dependency system, then in order for them to access residential treatment, they have to go through the Family Services Planning Team. The Family Services Planning Team is led in Circuit 7 by Children's Home Society. They will facilitate a staffing. Since COVID, all the staffings are held virtually, but there's opportunities for schools to participate in the staffing, post-adoption, crisis services, targeted case management. We also have Beach House, which is the Sens Fins program, and DJJ. A requirement of these staffings is that the parents do participate in those staffings, as the parents are making choices in regards to services. Maybe we could do, I probably should have started out with our first poll question, which was a little bit of background information. So Lori, maybe could you do that first poll question as we move forward? And that way I'll know maybe what to focus on. So we'll give it a couple minutes, or give it a minute or so. Thank you. Okay. So this will help me too. So in order to access the Family Services Planning Team, there is a referral. And again, they showed that training earlier today here at the summit, but You'll also have our contact information. So if you need a referral, we can definitely get that sent to you. But there's a simple, I think it's a 2-page referral that is completed. Families or individuals can fill it out as best as they can. It is sent to Children's Home Society. Vitra Small is the Family Services Planning Team Coordinator at Children's Home Society. Once you send that referral over to them, then they will schedule that staffing. Typically, the staffings in our circuit are held once a month by county. So in Volusia County, there is an east side and a west side that they schedule. And then once a month for Flagler, once a month for Putnam, and once a month for St. John's. If a child is in need of residential treatment, they will need to access the Family Services Planning Team first. Specifically, if they have Medicaid, if they have private insurance, then they do not need to go through this process. They would contact their private insurance company. But if a child is in need of residential treatment, they would access the FSBIT. Then typically those children have a targeted case manager, then that would put the residential application together, and then the child would be staffed at the child and family staffing and would continue to be staffed at that level of treatment while they're in residential treatment until they return back to the community. And back to the community, or residential treatment would include SIP, which is statewide inpatient psychiatric program, or specialized therapeutic group home, which can be either before or after a SIP, depending on the child's needs. Does anyone have any questions about that? Like I said, there was an earlier training about FSBIT and CFS, and I think that PowerPoint is available at the summit. I'm not moving forward. Okay. So next is the, let me get back, sorry. My head froze up. There we go. So next is the Integrated Practice Team, often referred to as IPT. The Integrated Practice Team is a staffing that's facilitated by both the Department of Children and Families, and in Volusia, Flagler, and Putnam, Community Partnership for Children co-facilitates, and up in St. Johns County, it's the Family Integrity Program that co-facilitates that staffing with the Department of Children and Families. It's a family-centered staffing, so parents or caregivers are required to participate, that they gather information and see what services can be linked to the family to try to keep that child safe and prevent dependency services. The child or the family, the case needs to be open in what we call FSFIN, and it could be through post-adoptions, non-judicial services, or can be an investigation. Typically, the investigator is the one that sends over the referral to the IPT staffing. Those are held 5 days a week. So depending on that child's needs, they can get those staffings held quite quickly. There's opportunities to participate in those staffings as those staffings are held virtually. But typically at those staffings, again, the parent, caregiver, you have Department Children and Families, the investigator, as well as the facilitators. If a child has complex mental health needs, then the mental health providers may be there at the table, as well as insurance plans there at the table. You can have the school at the table, Department Juvenile Justice at the table, again, to develop that plan to help keep that child safe. And there may be prevention services that are put in, and prevention in relation to dependency prevention that are put in to try to keep that child, again, safe and the family stable in the community. There are oftentimes, again, if that child maybe has complex behavioral health issues, that we may end up referring that child over to FSBIT staffing to help that family. But IPT will typically follow up for a couple of staffings just to make sure that there's no other issues. And again, prevent that that child or those children into coming into the dependency system. And again, there are opportunities for anyone to participate in those staffings. Either you yourself can make the referral, or you can contact the investigator to make the referral to the Integrated Practice Team. Next is the CPC, multidisciplinary staffing. This is to address mental health or behavioral health issues of a child that is in the dependency system, meaning they do have a dependency case manager. They look at the individual, the behaviors at both home and school, and try to, again, integrate services to help keep that child safe and stable in the community. This is also the staffing that occurs in order for children that are in foster care to access specialized therapeutic foster care, level 1, level 2, as well as specialized therapeutic group home or statewide inpatient psychiatric program. In order for foster children to be able to enter a specialized therapeutic group home or a statewide inpatient psychiatric program, they have to be recommended for an independent evaluation. And that recommendation will come out of one of these, the CPC multidisciplinary staffing. Those staffings are facilitated by the behavioral health coordinator. They're at Community Partnership for Children in Volusia, Flagler, Putnam, or the same with the Family Integrity Program. Participants in those staffings include the guardian ad litem, the dependency case manager. Sometimes if there's a parent or caregiver, they may participate in those staffings, the attorney ad litem. Schools can participate in those staffings as well. Anyone that is working with that child, you have foster parents that have participated in those staffings to be able to listen to those recommendations, as well as sometimes other maybe specialized providers. So the specialized therapeutic foster parent may participate as well as the insurance company participates in those staffings. And those staffings are held via conference call. And they were in person as well when we were doing in-person meetings. Next, which is something very unique to Circuit 7, is the DJJ multidisciplinary staffing. So DJJ does do, Department of Juvenile Justice does do internal multidisciplinary staffings, but this is in relation to community multidisciplinary staffings. So DJJ may facilitate a multidisciplinary staffing if there is a youth that maybe has, again, complex behavioral health issues. Maybe the family is experiencing some ongoing issues in the community and the family needs additional supports to be able to keep that child from being arrested, or maybe law enforcement continues to get called out there. They may contact DJJ to facilitate a multidisciplinary staffing. So typically in those staffings, they are facilitated by Zemetra Anderson, and usually participants in those staffings are the JPO. If the child is in a DJJ program, they may be on the phone, the parent or guardian. Maybe DCF has become involved at that point, Department of Children and Families. Usually myself, as well as the IPT team, participate in those staffings, and we may have other individuals based on that child's needs. We've been able to, if there's a child that is in the detention center, for example, and the parent has said, I'm not going to pick them up when they're released, then DJJ may facilitate that lockout staffing to try to come together to see what services can be put in place so that child can come back home. Do we have any questions about the last couple of staffings that we had spoken about? Next is the placement stability staffing. And the placement stability staffings are for youth that are in the dependency system that may be experiencing some behavioral health issues or some behaviors that may disrupt that placement. And CPC or Family Integrity then will bring together individuals that are working with that child, including the foster care licensing agency, to try to put in some interventions or some services to prevent that child from moving from placement to placement. They want to see what they can do because it can be traumatic for a child to be moved from placement to placement. Sometimes maybe it's a communication issue that the foster parent's frustrated, they can't get a hold of someone, or maybe the provider is having issues scheduling appointments. And so these staffings can help reduce those communication issues, as well as, again, put in additional supports to prevent that child from being moved from foster home to foster home. These staffings are held via conference call. So there's opportunities for individuals that are working with that child to participate in those staffings. You would just need to contact that dependency case manager to be invited to that staffing. Next is the local review team. So I facilitate the local review team, and this is a case-specific staffing. This is for case-specific issues that cannot be resolved at one of those lower level staffings. We do have staffings that occur once a month to identify systemic issues or gaps and try to work towards a resolution. And then we can also participate. We can also hold ad hoc meetings specific to individual children. Depending on the issue, it depends on who would participate in that staffing. Sometimes it may just be agencies that are on the phone to try to work out various issues related in a case. We often do have parents that participate in those staffings when there are complex issues. If we're not able to resolve those issues locally, we may refer that child or that family up to a regional review team staffing as well as a statewide review staffing. But the first level would be the local review team. Next is services that are available for all children and youth. This includes targeted case management services, and those are completed by community mental health providers. That is typically a Medicaid-funded service. So if a family is not sure where they can get targeted case management, they can contact their Medicaid health plan. They can help with a referral, but such examples are Halifax Behavioral Services, ESP Case Management, Children's Home Society, Medallion, A Helping Hand. So there's quite a few different providers within our area that provide the service. And then it would be up to the health, if they're on the health plan, to be able to provide services for that family. There are some of the agencies that do provide targeted case management services for adults as well. This is, as we may have an adult that is, say, a 19-year-old that's still in school, maybe experiencing some behavioral health issues, they could still be referred for targeted case management. It just has to be a provider that works with adults. Next is the SINS-FINS program. So in Volusia and Flagler County, that's through Stuart Marchman Act Behavioral Health Care. Often you'll hear families maybe refer a child to Beach House. That is a program through SINS-FINS. SINS-FINS, again, is children in need of services and family in need of services. You often hear that children with truant, ungovernable, and runaway behaviors are referred to the SINS-FINS program, and that is provided by Stuart Marchman Act Behavioral Health Care. In-home counseling services, again, typically that is a Medicaid-funded service. There are, again, providers within the community. You would just check, that family would just check with their health plan to see who that they would need to be referred to. Most of the targeted case management agencies I spoke about earlier do also have in-home counseling services, and they can be provided in the home and in the school. There's also a specialized program called Care Coordination, which is done through Children's Home Society, and that's for children that have high number of Baker Acts. It's managed out of the Jacksonville office. So if you call locally, they may refer you back up to the Jacksonville office, but that is the phone number there for the Care Coordination Program. They will provide coordination of services. It's at no cost to the family, as well as they have some wraparound that they may be able to find some wraparound funding for that child and that youth. Care coordination services are only up until the age of 18. They will have to discharge at the age of 18. Next is board certified behavior analyst services. A note for that is they will need a referral either from the primary care physician or a psychiatrist if they have Medicaid. Those referrals would go directly over to those behavior analyst service providers, and the family can contact Medicaid to see who the providers are in the community. There have been a couple of new ones that have popped up and have helped reduce wait lists. Again, next is Family Services Planning Team, which is through Children's Home Society. That's the phone number for Vitra Small, who facilitates that staffing. Next is the Community Action Team, our CAT team. Halifax Behavioral Services is our CAT team provider here in Volusia and Flagler County. There are CAT teams all throughout the state. If you have a child or young adult that is in need of CAT team services and they're living in another area, you can access that through the Department of Children and Families website. But this is the most restrictive community services that they have. So they will get a case manager, like a targeted case manager, psychiatric services, counseling services, as well as mentor services. And they can support that family 24 hours a day, 7 days a week. So there's also crisis response that is available for families that are for children that are involved in the CAT team. Next, we have the Mobile Crisis Response Team in Volusia and Flagler counties. That is through Stuart Marchman Act Behavioral Healthcare. That is a 24/7. Anyone can contact the Mobile Crisis Response Team. So if that child maybe, or even adult, is acting out, maybe they may need a Baker Act, and we'll talk more about the Baker Acts in the next part of the training. The Mobile Crisis Response Team can be called out, and they can help to try to de-escalate the situation in order to prevent the Baker Act. They will also provide family with resources. We're fortunate here that in our area, there's no age limit in relation to the Mobile Crisis Response Team, so they will respond to any age. Next, if you're trying to access services and you're not sure where to go, you can contact or a caregiver or a consumer. So if you're working with a young adult, they can even call themselves. They can contact the LSF Access to Care line, which is on here. That is housed 24/7, and they will help refer that individual to services within the LSF Health System network. There's also the myfloridamyfamilies.com. So if you have a family, maybe you're trying to look for some housing resources, you can look on the myfloridamyfamilies.com. You can put in the zip code, and by there you can look at various resources for an individual or family. Families can even access that themselves. Not every single provider is listed in there across the state. So again, if they have Medicaid, you may want to tell them to contact their Medicaid plan, but it is a tool that can be utilized to access help for families. Again, including, it could be medical help, housing. It's not limited just behavioral health issues. That is going to conclude my part of the staffing. Did anyone have any questions before we jump to the Baker Act?
Not seeing any questions in the chat, Christy. So
okay, perfect. It also uploaded into the webpage is going to be information on again with the phone numbers and emails of who you may contact if you are trying to seek help for a family.
Hi, everyone. So now we're going to cover children's mental health. Lori, can you do the last poll that we have, please, at this point? And we'll give everyone a minute. Okay, so are there differences between a Baker Act for an adult versus a Baker Act for a child? Yes or no? And we'll just give it a minute. Lori? Okay, so yes, there is a difference between a Baker Act for an adult versus a child. So, and we will go through that a little bit. Okay. So next slide.
Freezing up.
Okay. So some of the things I want to talk today about is the Baker Act, but also I want to talk to us about getting to a Baker Act, what we can do to avoid a Baker Act. So we know that mental health problems are common. And there's unfortunately a tremendous stigma attached to that. And a lot of times, especially with children, not only between children and children is there a stigma, but a lot of times when we approach a parent and say, you know, hey, I think that there might be something going on with your child. It is taken, and as a personal maybe attack on the parent. They immediately sometimes feel that they have done something wrong, that it's their fault, that we're saying they're a bad parent. And none of that is true. But I think we can all understand how a parent can feel that way. It's just no parent wants to admit or face that maybe their child has some challenges that other children may not have. So there's a huge stigma with that. And we do have to look at how we bring that up with a parent and address that with a parent, because it absolutely, in most cases, is not anyone's fault. Those of us with mental health issues are born with them, or we get them over time due to certain circumstances. They're even inherited and genetic. So it's just kind of the lucky draw, I guess. Then we look at the professional help is not always available. So it's really difficult when we want to go and address that with a parent or a family, but then we don't have the support to offer them, or there's wait lists, or they're in a really rural area and there's just not the abundance of services. And then if there's a cost, that can be, difficult too for a parent. And so individuals with mental health problems often do not seek help, especially, if there's children, sometimes the parents might not seek that help, as we've talked about just now. And then as we get to be adults also, sometimes there's other barriers. And again, even the stigma follows you through childhood to adulthood. So there's a lot of not wanting to admit that you have a problem and that you need some help, or not want anyone to find out. And a lot of people are well informed and don't know how to respond. I can say that this is absolutely true. When I have confided in people before, there's been an array of responses. I can look back now and smile about some of them, but some of them it still baffles me a little bit. But we just don't know how to respond to everything. We're in this field, most of us that are on this training right now are in this field, but a lot of people are not, and it makes people uncomfortable. And I can understand that. I think it's the same as if someone comes to us and says that they have a serious illness, because mental health can be a serious illness. And I think that people don't know how to respond. Do you say, I'm sorry? Do you say, what can I do to help you? If they have their own issues with mental health or stigma, they might not respond well or know what to say or how to deal with it. So what can we do to kind of counteract those things? We can learn how to notice when someone needs help. And so it's difficult with a stranger, but sometimes you can notice that if you, obviously, if they're asking for help, if there's, really big red flags, like maybe something, maybe they're not making sense. Maybe they're talking very manic. So it could be that they're having a schizophrenic episode. It could be that they're having a psychotic episode, or just really not dealing very well that day, or managing possibly a bipolar diagnosis. So we can notice in that way with strangers and people we don't know. But there's a lot of times we can notice with people that we do know. And that's when they start to do things that they might not have done before. So if someone is very social and then all of a sudden has really withdrawn and started to hibernate and cancels plans all the time. If someone is sleeping a lot or not sleeping very much at all. So those are times when we can kind of notice. And then what we can do is be that person that talks to them about it, refers them for help, or if we're not comfortable talking about it with them, that's okay, but then refer them to someone who is, get someone who is comfortable, and promote understanding. I say this all the time, and we're in this month now. So May is Mental Health Awareness Month, but when I do this training and I normally ask people what month it is and what color, and it's green, people don't know. But if I ask people what is Breast Cancer Awareness Month, they all know it's October. They all know it's pink. And I think that again goes to show the stigma. So we need to promote understanding. We need to say, hey, mental health is like having a cold. It's like having blue eyes. It's just part of us as people. It's just like if you have cancer, the flu. So there's no difference. It's just an illness. It's just another illness, or it's another factor of our personality or a person. And then encourage community members to support one another. And I think that that's also a very big part of this. So not only with the mental health and substance abuse providers, because we get that, but also having other agencies making sure that they're supporting their community members. Even if they're not a mental health provider or a substance abuse provider, they might be that first interaction with somebody. So for instance, a domestic violence center. They're not necessarily a substance abuse or mental health provider. Obviously, they might have those services in the center, but if they're a community member and a community agency that supports the mental health and substance abuse community, that goes a long way. People may feel comfortable in going to them when they're there and seeking help. And then help more people and get the help that they need. So we've got to get better at referring the appropriate services. If I am referring a child with an intellectual disability to a mental health provider and they are not trained in intellectual disabilities, that's really not going to help that child. That is something that should be helped by services on the APD side, Agency for Persons with Disabilities. So there's different services, and mental health and intellectual disability and developmental disability are all 3 different disabilities. They are treated differently. You can't take one and treat the other with that. So they're very, very different. And I think that a lot of times when we talk about understanding in the community, we need to promote that, especially in our legal system, because I think when lawyers get up and judges are there and they're listening and they're saying, nope, this is what the child needs, and it is clear intellectual disability, a lot of times it gets over into the mental health lane because everyone in that room says, well, it's got to be mental health, when it might not be. And again, that won't be the appropriate treatment for this child or adult. And then learn how to intervene, and you might save a life. I can tell you this, you never know what you're going to say could really stay with somebody and take that with them through their lifetime. And there's an old saying of don't ask what's wrong with you, but what's happened to you. Because again, mental illness is not wrong. We didn't do anything wrong. It's really what happened to that person. And years ago, a doctor, I don't know who it was. He wasn't my doctor. I was in the hospital. He came up and he stood there, and I woke up and he said, this must be really hard for you to deal with. And then he disappeared. I don't know who he was. I just know he was a doctor and a coach. And that has always stayed with me all these years later, because that was the first time that anyone ever said that to me. And it is true. It's very challenging to navigate the mental health system, but it's also very challenging to live with a mental health disorder and be a part of society and, dealing with all the stigma and all of the things that we just talked about. So learn how to intervene, and you really might save a life. That might be the day that person says, you know what, I need help. I'm going to go get it. Okay, so next slide. So the first step, after we educate, after we provide that understanding, after we get the parents involved and they understand that, it might not be an actual disorder. You might have symptoms of something, or it might be behavior, whatever that is. So after we're there, what can we do to offer the parents and provide help? So there's targeted case management, which is through Medicaid. There's outpatient, so that might be going to a therapist and, having them utilize DBT, dialectical behavior therapy, or CBT. So, and again, we probably want to look at the therapy that's offered, the evidence-based practices, and make sure that they line up with what the child may need, if at all possible. If not, go ahead and refer to the provider, and they should be doing that. We have the CAT team that Christy talked about, the Community Action Team. We have the Mobile Crisis Response Team. So in some areas it's called MRT, in some areas it's called Crisis Response Team, but it's all the same. And I believe in your area it's more looked at as the Crisis Response Team. But again, Christy went over what that team entails. And then behavior analysts. So that's an evidence-based behavior therapy that focuses on developing appropriate behaviors in children. So we're going to minimize those negative behaviors such as cutting or aggression, so such as hitting or even hitting themselves against the wall. So that's a really good resource. Unfortunately, in the state of Florida, some areas in Florida do not have an abundance of these. So there's either a wait list or there's a long drive to even access that service. So again, something that you can do is get out there and say, we need this to anybody who has funding, anybody who has a grant, anybody who will listen. You know, we need these services so we can best help our kids. So that's the first step. We want to exhaust all of this before we go to the next step. And I think a lot of times what is happening is we are not hearing from these children and these families until a little bit later. When things have progressed, because again, that misunderstanding of mental health, that stigma, all of the things that we've talked about, not knowing how to navigate this system. This is a system. This is not going into a store and buying a product. This is a system, and it's hard to navigate. We have our acronyms. We say TCM. What does that mean? Targeted Case Management. What does that even mean? Like what service does that provide? So we really have to break it down for the family. So it's an excellent opportunity when we have our staffings, our family service planning teams, or any MDT, again with the acronyms, multidisciplinary staffing, to explain to the parents, break it down. I remember years ago, someone told me I could not train someone individually. I can do a training like this and offer the information, but I was training somebody and I forgot them. I walked around, I did all of this stuff, and my boss was like, you can't train because you think you know it, and well, you do know it, and you think that person knows it, and so you're off and running, and that person is still left here thinking, wait, I don't know it. So it's a skill, but we have to start to do that. We have to start to remember that we are talking to people that do not understand our system. You might be surprised, might not even know what it means when we say outpatient treatment. They might not know that. So we have to be sure we're breaking that information down for them every single time. Because I don't know about you, but you can tell me something one time and you might think I get it, but then the next time I might need it again. So this is a foreign language. Think it is. It's a foreign language. I could go to someone off the street right now and say, behavior analyst, and they might not know what that means. So we have to be doing that all the time. And that's all of us. Anytime we touch a family, we should be educating them, no matter what your role is, whether it's a CPI, whether it's a case manager, whether it's someone in the behavioral health world, whether it's someone getting Medicaid and signing up for food stamps, whatever that is, take that time to start educating. Next slide. Okay, so the second step, which we would like to try to not do, is residential. Because even though everyone, wants residential, it seems like that's not always the best place. And we want to try to avoid that. That can be traumatizing for the youth as well. So we want to try to avoid that, but that's a higher level of care. It's obviously a locked facility in Florida. You may have heard it referred to as SIP. That is if it's being done by Medicaid. But residential services. So when do we utilize this level of care? When it's recommended by a psychiatrist and when we have exhausted all of the other first steps. And so that's what that should look like. It should look like our very, very last option for this family. And so the first steps, don't just try one. We need to try them all before we get to residential because there's a wait list. And again, we need to make sure we're referring the right children to residential. Remember, someone with a intellectual disability that does not have a co-occurring true mental health disability does not belong in a residential mental health facility. That's the wrong placement for them. They would do much better at an APD group home. Next slide. Okay, so as we mentioned with the poll, Baker Act for children is different than Baker Acts for adults. So go to next slide. So most of us are probably familiar with what a Baker Act is but again, we need to make sure we're educating people and parents on this. So when we say Baker Act, that's a Florida term. That's not nationwide. It came out of a statute. So it's an involuntary examination and it has to be initiated by either a circuit court can enter an ex parte order stating that a person appears to meet the criteria, or a law enforcement officer can take that person in who believes that they meet the criteria. They can take them into custody and deliver them to the receiving facility or CSU nearest them. And then thirdly, obviously, is a licensed psychiatrist, physician, clinical psychologist, all of those things that are listed in the statute under 394.455. So they can also initiate a Baker Act. So not everyone can initiate one. And obviously this is for involuntary. So that means that they're not voluntary saying they want to go. Okay, next slide. Primary purposes of the Baker Act. It is not for long-term treatment. It is just for stabilization. And again, I think this is where we can do better with our families and our parents and educate them. I think a lot of them think Baker Act, locked facility, residential treatment, and that's not what it is. So we need to let them know your child is not going to be there for a long time. They're going to be there until they're stabilized, not better, not treated, not well, not cured, but until they're stabilized. So obviously till they're better, but stabilized. We need to make that very clear. There's a difference between stabilizing and curing or treating the whole thing, and your child comes out and everything is roses. There's a difference with that. There's required timeframes for evaluation and treatment. There's maintenance of that treatment environment, and obviously there's rights of individual surge. All of those are guidelines and procedures that are mandated by statute. Next slide. Okay, so we've got screening services, legal standards, admission, and discharge. So we'll go through what each one means. Next one. So the process for each facility has, the process for each type of admission has different criteria. So you can have an involuntary or you can have a voluntary. Now for children, a voluntary, well, we'll get into that, but you have an involuntary and then you can have an express informed consent, meaning I could go today to a CSU, crisis stabilization unit, where you go if you're Baker Acted, and say, I'm not feeling well, I feel like I might hurt myself, this is what I'm going through, and I can, if I'm assessed to meet criteria, they will let me in on a voluntary status. Next slide. Okay, involuntary examination. So that, again, is initiated by one of the following: a qualified professional, law enforcement, or the circuit for the ex parte order. And that's for children and adults. Next slide. So involuntary criteria. They must meet all of the following criteria. So there's a reason to believe the person has a mental illness. Again, it excludes developmental disabilities or intoxication or substance abuse impairment. Next. Because of their mental illness, the person has refused voluntary examinations, and the person is unable to determine for themselves whether that exam is necessary. Next. Without care or treatment, that person is likely to suffer from neglect or refuse to care for themselves. So that poses a substantial harm or threat to the person. So it has to reach a certain level of neglect. And it's not, and it has to be that such harm can be avoided through help or other means. So we're talking like a threshold of high neglect with no other supports or systems in place. Next. And there's a substantial likelihood that without that care or treatment, the person will cause seriously bodily harm to themselves or someone else. Next. So how do we know if someone meets that criteria? Next slide. Factors to consider: refusal to take prescribed medication. Obviously, think about if someone is diabetic and on insulin, that would raise a concern of that person's going to have seriously bodily harm eventually from that and put themselves into harm's way. So that might be where we're talking about that neglect, that they're not going to take their prescribed medications, but that it leads to a serious issue. So, if it's, I can't think of another prescribed medication, but if it's not something that's going to lead that person to be physically in danger or behaviorally in danger, that wouldn't meet the level. Refusal to eat or drink over time, obviously that can cause a person to be in extreme danger physically. Large amounts of expired or unused food in the home, inability to sleep, placing oneself in imminent dangers, relationships, high-risk behaviors. So like some of our kids who might be always running away, going into what we believe is probably a high-risk behavior of human trafficking or drugs or gangs, things like that. So obviously they're placing themselves in that danger, and that's a high-risk behavior. And then again, neglects household or property or hygiene to the point they put themselves in serious risk of physical harm. Next. Okay, so a homicide or suicidal assessment. So this is for homicide only. We need to know who the intended victim is, plan, intent, and related behavior. So obviously, if someone just says, I just want to kill somebody, we need more information, right? We need to know who, and if there's a plan, and if there's true intent and the related behavior around that. Next slide. So again, who does the client intend to hurt, and can they get to that person? Is that person in California and they're in Florida and they have no transportation? Who are they actually intending to hurt? Is it everyone? Are they being vague, or is it a specific person? Next. And how does the client intend to cause harm? So this is for suicide or homicide. I always ask this question: how do you plan to do it? So if you have a plan, I get more worried. My red flags go up. Because then you've thought about it and you have a plan and you're more likely to act on it. Now, I want to make it very clear here. A lot of times too, people just get very, very upset and they do something and they take a bunch of pills and they, try to commit suicide. They didn't have a plan. It just happened. It was in the moment. So it's not always that there's a plan. But if there is a plan, that kind of does make us want to ask a few other questions and look at it a little bit more. Is it realistic? Is it potentially lethal? And can that person gain access? So if someone says, I want to shoot myself, do they have access to a gun? And where is that gun? And, is it here or is it grandfather's 8 hours away? Those are things that we need to take into consideration. But again, just to be clear, even if they might not always have a plan, it doesn't mean within an hour they get really upset and they do something that they can't take back. So we've always got to be looking at that and being our eyes open. Next slide. And then does the person intend to carry out the plan? And that's for homicide or suicide. Do they have a specific time frame? Are they saying one of these days I'm just going to kill this person, or one of these days I'm just going to really hurt myself? And are there qualifiers? So is it the next time, my husband does this, I'm just going to do this to him? Or is it, a very specific time frame? Next slide. And then has the person tried to kill or harm themselves in the recent months? Obviously, we look at that. That can tell us a little bit of the likelihood, and again, possibly the way that they've done it in the past, so we can be more aware. And also it can let us know that things might be escalating with this person, or that they are decompensating. Has the client made suicidal gestures or attempts to kill themselves? Have they been hospitalized? And then has the person exhibited uncontrollable outbursts in recent months? So these are all things that we want to take into consideration. Next slide. So the examination has to be determined within 24 hours. The evaluation has to be conducted by a psychiatrist, other physician, or psychiatric nurse. And it has to include personal observation of recent and review of recent behaviors, review of the required documentation. So if there's documentation that's in their system or they were able to get it from another facility, a brief psychiatric history, and then a face-to-face examination. Next. So additional requirements for minors. The minor one has to be done within 12 hours. So it has to be initiated within 12 hours, not complete, but initiated. And in addition to the requirements for adults, they have to look at the following. They have to look at the current and past mental and physical health, overall functioning and coping skills, their academic performance, possibly their IQ, social and family interactions and relationships, behavior and how they manage their emotions, how they cope, and then discharge needs. Next. So again, here we go into the parental consent and admission discharge. So next slide. So there's no difference in the initiation of an involuntary examination for minors and adults. So that part where we initiate, no difference. Part where we do the assessment and within the 12-hour frame versus the 24 and those added factors, that's different. Now, you do not need parent permission to initiate an involuntary examination of a child or adolescent. If you feel that that child is in harm's way, then you would initiate a Baker Act. Next. Now, voluntary admission, though, minors cannot be legally admitted on a voluntary status unless that minor's legal guardian has applied for the admission, the minor's in agreement, and a judicial hearing has been conducted prior to the admission. So a lot of times we are seeing our children involuntarily Baker Acted, and that is why. Next slide. So within the 72-hour time frame or time period of the next working day, the patient shall be released or the patient shall be returned to the custody of law enforcement if they've been charged with the crime. And if they were picked up by DJJ or law enforcement, they first will be processed by DJJ and law enforcement before they're brought to the CSU. And then if they need to be returned, then they'll be returned after the Baker Act. The patient can be released for voluntary outpatient treatment. The patient shall be asked to give express informed consent to voluntary placement, or a petition for involuntary outpatient or inpatient placement shall be filed by the facility. So that means extending the Baker Act, and you have to go before the court to do that. So again, within the 72-hour time period, one of the following of these must occur. Next, requirements for release. So it has to be done by the approval of a psychiatrist, and they have to, make sure that at this time they are stable. But that's how it has to be done, by a psychiatrist or clinical psychologist. Go ahead. Or in some cases, a psychiatric nurse. Okay, discharge planning for minors. Children should not be leaving the CSU without a discharge plan. Sometimes that discharge plan might be buried in a stack of paperwork. So again, we need to educate our parents. Sometimes our parents will say, well, they didn't tell me what to do. But then when we look into the packet a few pages down, there's a discharge plan. Obviously, we should be going over that discharge plan with the parents before release. But if that doesn't happen for whatever reason, we need to make sure that there's a discharge plan for that minor. So again, educating your parents, saying to them, make sure you ask about a discharge plan. Are there family needs that should be addressed to support the minor's treatment? So here again, let's say you have two siblings and one of them is going through a difficult time, having some mental health issues, getting Baker Act over and over again. Guess what's happening to that other child? Now they're starting to have some issues too, because they're either not being, they don't feel they're part of the family. They feel all of the attention is going to their sibling, or that sibling's behavior is just impacting them. And we forget about that a lot. And we can't, because mental health does impact the entire family. Even as an adult, it impacts the family. It impacts a marriage. It impacts your relationship with your adult parents as an adult. So it's not something that just impacts you or the person. So we need to look at those kids and say, hey, do they just need a mentor or a peer or someone they can talk to, since right now a lot of the attention and focus is on this other child? What services and community programs can meet their current identified needs? Again, we go back to the first steps, making sure though it's the right kind of service, it's the right kind of community program. We can't do cookie cutter because we're not cookie cutter. So we're not all alike. So our discharge plan should look different, and we should make sure that they are meeting the needs of that particular child. And then again, the mobile response team should definitely be provided upon discharge. That should be an automatic. And you can also provide that at any time to the family and say, here, if you ever need this, here you go. So, but again, these are things that we need to look at with discharge planning. Next. And then for additional information, there's the forms and link. Now, I do want to talk about a couple things, but I know that we are facing a time thing. So I just want to say this. Please make sure that with the discharge planning, that we ensure that that's happening and that parents know that that is something that has to happen. And also, we need to watch our children more in our community, because recently I found out that we are seeing a rise in Baker Acts for children. And now there is a hashtag going around in some schools and in some areas. It says hashtag cutting, hashtag suicide, hashtag Baker Act. I don't know about all of you, but when I grew up, I did not know what a Baker Act was. But our children seem to know what it is. And it's not a good place to go over and over again. So if we are having to do that, we need to figure something out. We need to then go back to the discharge planning and figure out, okay, every time you've discharged them, that you're discharging them to this program. Obviously, this isn't working. Let's rethink that and do something different. And then we do need to treat the family as a whole. If we send a child to residential and that family is not engaging, guess what's going to happen? They're going to come back into the home and they're going to end up in the CSU again, or asking to go to another residential in a few months. It's hard to parent. It's why I don't parent, because I know it's hard. And so it's hard enough to parent children in today's society. Then you add on the added challenges with mental health, and it makes it even harder. And we're not given a plan to say, here, this is what you do. We kind of make it up as we go along. So for parents, it's very difficult. So we need to make sure that they are getting the support that they need. The other kids in the home are getting the support that they need, so that we can really support this family and have success. Okay, I'm done now.
I want to show, hold on, I'm going to share my screen again. Just for everyone's reference, I did, can everyone see the quick reference guide?
Yes.
Okay, so it is loaded onto the page. If you are trying to get help and services for any of your clients or families, this is just a quick reference. So if you have a family that's 0 to 3 and they're looking for services, there's information for early steps, home visiting referrals, Healthy Start. There's also where families can apply for insurance, Medicaid, the LSF Access to Care line. It also has the different levels of treatment that are available. If you have a family that has a child that's been adopted, here's our post-adoption contacts for Circuit 7. If you're working with a family and involved in either foster care or kinship care, or you need the behavioral health coordinator at Family Integrity, there's their contact information, as well as resources for respite, power of attorneys. Like I said, I'm going super quick because I know we're out of time. The IPT, the DJJ multidisciplinary staffing, again, targeted case management, FISBIT, FACT team, as well as information on Agency for Persons with Disabilities. You have the Mobile Crisis Response Team information, Baker Act, Marshman Act, as well as leadership within Circuit 7. So if you're having issues maybe with a family that just has a CPI, here's Charles Puckett's information. You're working with a family and they're struggling with behavioral health or substance abuse issues. Here's Erin Whitaker House at our managing entity. Here's the Children's Services email. We'll also go down to, again, the early steps, Early Learning Coalition, how to help your families access daycare as well as other early intervention programs. And then we have all the Medicaid plans that are available, including what type of transportation that they may have. So this is, again, a quick resource guide. It is available on the homepage or the training page documents if you wanted to take that with you. There's a lot of really good information there.
Do we have any questions? I know we're out of time. Yes, Jessica. Oh, no, I think she was clapping. Okay. Thank you, everyone.
Thank you.
I'm not seeing any questions either. Thank you very much, both of you, for the panelists and for all the attendees.
I do have a question if I could.
Okay.
This is Mary with ESP. Megan, you did say that you're seeing a big rise in Baker Act. However, with the children that we're dealing with, the Leos are not doing Baker Acts on them. They'll go out by the time they get there. Some behaviors can just be awful, but they refuse to do a Baker Act. Can you put any kind of light on why?
I can't because I'm not there. So it's really up to the law enforcement if they meet that criteria that we went over. Law enforcement at that time might not think so. A lot of times too, what happens is law enforcement does take them, and by the time they get to the Baker Act facility, they've calmed down. And so then the Baker Act facility doesn't accept them. You can reach out to me and maybe we can do a training with that law enforcement agency and see where your concerns are coming from. But statewide, we are definitely seeing a rise in Baker Acts. But unfortunately, since I don't know case by case, I don't know what they're seeing, that they're not doing that. If you feel,
I was going to add, sometimes we hear like specific law enforcement agencies don't like the Baker Act, so it could be specific to a law enforcement agency. Something else that families can do here in our area that we're fortunate to have. Any family member can bring a child into a screening for services at Halifax at no cost, 8 to 8, Monday through Friday there at Halifax Behavioral Services. They can screen them for the Baker Act as well as screen them for other services if they're not meeting a Baker Act criteria. So that's something else that we have in our area.
Any other questions? All right, again, thank you both, and thank you for attending this session. I've put a link in the chat for an evaluation survey if you would take a moment to complete that about the summit. Also, I've sent the link as far as going back to look at our sponsors' profiles and our virtual exhibitor hall. And we do hope you enjoyed the Health and Human Services Summit 2021 and see you next year. Thank you, everyone.
Thank you.
Thank you.